Okay, welcome to lecture 3 on extremity trauma. Two important subjects we're going to cover in this lecture. We'll try and keep the lecture as short as possible, but there's a couple of really important concepts that you need to grasp within this lecture. We're going to talk about compartment syndrome, and we're going to talk about crush injuries. Okay, so firstly, compartment syndrome. It's most common in the forearm and lower legs, and it's as a result of swelling which compresses nerves and vessels. Okay, so the extremity contain muscles and other structures, and these muscles and other structures are surrounded by a fibrous type of tissue, and this tissue is known as fascia. It doesn't stretch, and it creates multiple closed spaces within the limb. Okay. As the area swells, and we'll discuss what can cause that swelling just in a minute, but as that area swells, pressure is transmitted to the blood vessels and the nerves. So if you think about each muscle is contained in a compartment, and then you have swelling of the muscle inside the compartment doesn't stretch, but then you get that pressure build up inside the compartment. You've got vessels and nerves running into that compartment as it stretches, and as a result of that fibrous membrane not allowing that stretching to happen, you get compression of that vessel inside that compartment, and you get compression of that nerve inside that compartment. Okay. So blood vessels, so it will compress the blood vessels and the nerves in such a manner that it will reduce circulation, and the nerves will also be compressed, and these injuries usually develop over a period of hours, so it can take quite a while for these injuries to develop. Right. As far as etiology is concerned, there are a couple of reasons that this can happen. The first is as a result of a decreased compartment size, and this could be from casts or dressings or splints. Okay, so like air splints, or when people have casts on, or if dressings are applied and those dressings are applied too tightly, you could get a compartment. The next is from increased compartment content from vascular injury. So you may have some kind of a vascular injury, something like burns, which will cause the vessels inside the compartment to become leaky, and you'll get extravasation of plasma into that compartment, which will then increase pressure inside that compartment. Okay, could be as a result of envenomation. Same thing, you can get leaky vessels as a result of envenomation, or as a result of tissue to IV fluid. So if you go and you place an IV line and you get it into a compartment and you tissue that fluid into that compartment, you're going to get an increase of intracompartmental pressure inside that compartment. And then as a result of externally applied pressure from a tight dressing or poor limb positioning. So if you've ever laid down on your arm and you wake up and you've got pins and needles in your arm, effectively what you've done is you've caused a compartment, and as a result of compartment syndrome. Because you're healthy, your body's able to deal with that, but patients that are sick, that are not healthy, and they have continuous pressure on a limb, you can get a compartment syndrome. It's just a cascade of things that happen. More leaky tissues, more compression. The more there's compression, the less there's blood flow into the area, the more swelling there is, so it's a cycle that just continues. Okay. So the early symptoms of compartment syndrome are pain and paresthesia. So paresthesia are those pins and needle, is that pins and needle feeling that you're going to get in that limb. All right, and then late symptoms, also pain and paresthesia is a part of that, but you're also going to get pallor, which is paleness, pulselessness as you get more and more swelling. So the blood supply to that compartment is completely decreased, and you're not going to get distal pulses, and then paralysis, so complete paralysis as a result of the nerves being damaged. So if you have a look at the diagram over here, you can see the muscles over there, and in between the muscles you have your vessels and your nerves. Okay, and as these compartments start to swell up, right, and that compartment there starts to swell as a result of injury, it will compress against those nerves and those vessels over there. And once those nerves and vessels are completely compressed, you're not going to get any additional blood flow into the limb, right, when you have yourself a compartment syndrome. It develops over hours. You need to be reticent of it. Not reticent, you need to be aware of it. And these patients need to get to hospital as quickly as possible, because they will need surgical intervention to release the pressure. And it's usually done through a fasciotomy, where the fascia, or that fibrous tissue that's preventing the limbs or the muscles from swelling, is sliced open, and it allows the decrease of pressure. Okay. Next, we're going to talk about crush injury. Okay, so crush injury It can be a little bit complicated, but I'm going to break it down for you so you can understand each component of crush injury individually, and then the bigger picture will make sense. So crush injury happens when pressure is exerted on an extremity due to prolonged entrapment, and this can disrupt blood flow. So when released through extrication, reperfusion syndrome may occur, and toxins built up in the injury enter the central circulation. So basically you have tissue or a limb that's crushed. Because of the crush, you get a bunch of toxins built up inside that limb, and as soon as that limb is released, all those toxins that have built up inside that limb are released into the central circulation, and that causes issue. Okay. So these toxins that we're talking about, all right, there are three main types of toxins that we're going to discuss, all right, and the first one is potassium. So all our cells contain potassium, and if our cells are damaged, then potassium from the damaged cells will enter circulation. So this will lead to cardiac dysrhythmias and the resultant hyperkalemia. So you want to look out for peak T waves, you want to look out for QRS widening, and you want to look out for the absence of P waves in your ECG tracing. Okay. This can cause a fatal dysrhythmia, so you need to prepare to resuscitate these patients if required. Okay. If you think about potassium as a lethal sort of component of our natural chemistry, whenever somebody is put in or whenever somebody is about to get the lethal injection, the compound that they use to actually stop the person's heart is potassium chloride. Alright. So potassium, as much as we need it for that action potential within our cells, where we have sodium and potassium constantly moving in and out of our cells to create that action potential, it can also be dangerous if too much potassium is released from those cells and enters the central circulation. Okay. The next thing we want to worry about is myoglobin, and myoglobin is released as a result of damaged striated muscle cells. Alright, so you get lysis of the muscle cells, and as the muscle cells are broken down and the muscle cells are damaged, alright, obviously from that compression, okay, that myoglobin, which is a byproduct of damaged muscle cells, enters the plasma, and then it gets into the central circulation. It has to go to the kidneys to be filtered, and when it gets to the kidneys, it's filtered by the glomerulus. Right. And what happens is if your pH is too low, what happens to the myoglobin is it forms a kind of gel in those distal tubules of the kidneys, and it clogs up the kidneys, and the kidneys aren't able to eliminate any more of that acid. And we'll talk about acid in a moment, but acid is also as a result of cellular damage within the area that's been injured. Okay. This is known as rhabdomyolysis. So if you get that myoglobin release as a result of damaged striated muscle, it's called rhabdomyolysis, where you get lysis of the muscle tissue and then the subsequent release of those inflammatory markers or myoglobin. Okay. This can also happen as a result of exercise. So if any of you are like CrossFitters, and everybody brag, if you do CrossFit, there might be a time when you brag about getting rhabdo. Okay, rhabdo is no joke. You can get kidney failure from it and you can die. Alright? And that's what rhabdomyolysis is. It's the breakdown of muscle tissue and the subsequent release of myoglobin, which gets stuck in the kidneys and causes kidney failure. Finally, we're going to talk a little bit about acidosis. Alright? So acidosis basically means that you have a low pH. So our body's normal pH is anything between 7.35 and 7.4, right? Or 7.3 and 7.4. And our body is pretty sticky about remaining at that sort of level of pH. Okay. What happens as a result of the crush injury? There's really two mechanisms that can decrease your pH, and the first mechanism is blood loss. Okay, so if you have blood loss or concomitant injuries with your crush injury and you have blood loss, your body's going to go into a state of anaerobic metabolism where it starts to use other forms of energy other than oxygen and glucose, or glucose, sorry. And this causes a buildup of lactic acid. So we all know that lactic acid comes as a result of metabolism that doesn't involve oxygen, so we get that lactic acid buildup, and then we get the resultant clearance issue through the kidneys. And then the second mechanism that we get an increase in acid is from acid components which leak from those muscle cells that have been damaged into the surrounding plasma, which then enters the circulation. So really two mechanisms of increased acidosis. So think about it. You've got the increased acidosis, and we know that the body's way of getting rid of acid is through the kidneys. So you have an increased need for kidney function, right? As a result of the increased need for kidney function, you've got a lot more flowing through the kidneys, but you've now also got myoglobin that's getting stuck in those kidneys. As your body starts to get rid of fluid, your blood will become sticky. That myoglobin will become sticky. It will form a gel. Your kidneys won't be able to get rid of that acid anymore, and as a result, the acidosis will increase. At the same time, you've got issues from the potassium entering your heart, causing dysrhythmias. So there's an entire cascade of things that happen during a crash injury. All right, let's talk about treatment for crash injuries. All right. So you need to conduct frequent ongoing exams. And when you talk about frequent ongoing exams, you want to monitor the vital signs using your ECG. Right? So you're looking out for those aberrancies in the ECG. So you're looking out for those peak T waves, you're looking out for those Weidman-Chiari complexes, and those flattening out P waves or non-existent P waves. You want to have a look at your end-tidal CO2. So that's going to give us a good indication of how our lungs are getting rid of some of that acid or some of that carbon dioxide that's built up in our lungs. So we can eliminate some acids through the lungs, and we want to target a end-tidal CO2 of between 35 and 40 millimeters of mercury. And then finally pulse oximetry, which will give you a good indication of the oxygen level in the blood. We want to try and alkalize the blood, and this can be achieved through the infusion of sodium bicarbonate. So this will help to just balance out some of those acids and reduce the need for the kidneys to function at a very high level during a crash injury. So sodium bicarbonate is important. It's a CCP skill, so you want to go ahead and get CCP assistance for the sodium bicarbonate. You're then going to want to deliver large volumes of intravenous fluids, okay, and this is again to assist the kidneys to work correctly. And this is going to be a bit of a balancing act. This is one of those times when we're not going to use hypotensive resuscitation because we want our kidneys to survive this, the insult that they just received as a result of the crash injury. So it's going to be a bit of a balancing act between titrating your fluids so that we've got good kidney function, but we also want to optimize our clotting factors if we've got a polytrauma patient. And this is really where we're going to need early contact with our medical command or the receiving trauma facilities so that they can advise us. Okay. Once again, CCP assistance is going to be required here because there's a very delicate balancing act that you need to perform with fluid resuscitation on these patients. If you have an osmotic diuretic such as mannitol available to you, you want to go ahead and give that to the patient. Again, I don't think it is part of the scope of practice in QAS, although CCPs may have mannitol on their scope of practice. If you're working in the austere environment or not working within QAS, you may have mannitol available to you to give to these patients. So administration of fluids, if administration of fluids or medications prior to releasing the entrapped body area is not possible, then you want to go ahead and put a tourniquet proximal to the injury site on the extremity. Right. So you've got all that buildup of toxins inside that extremity. If you can't manage those toxins through medication and through large volumes of fluid, what you can do is you can put a tourniquet on the patient's limb. Right. So if I've got a crash injury to my arm, I'm going to put a tourniquet above the crash injury, which is basically just going to decrease any blood going into the limb and refuse any blood from coming out of the limb. We're not going to get that. We're not going to get those toxins going into the rest of the body. The tourniquet is going to prevent that from happening. Once you get your patient to hospital, they can release the tourniquet and they can manage that influx of toxins into the body once the tourniquet has been released. So go ahead and apply tourniquets if you can't manage the injury in any other way. Okay. Again, early contact with medical command or your receiving trauma facility is super important for these patients. All right. That's the end of the lecture. I hope I haven't made it too complicated for you. I'll see you in the next one.